preliminary.
All right, it's 10:01, so we're going to go ahead and get started. Good morning, and thanks for everybody joining us today. I'm Justin Davidson. I'm the president-elect of SMPS Nashville, and this is sort of an unprecedented time, and we have pivoted with these times, and we're trying to continue to provide you with programming that we hope adds value. And today we are lucky enough to be joined by 4 experts that focus on architecture, engineering, and construction for the healthcare industry. And they will discuss what we know, where we're headed, and what information they think should be shared. And we thank them so much for taking time out of their busy schedules for this event this morning. And this event and others would not be possible without the ongoing support of all of our annual sponsors, and they are Turner Construction, Dunn Construction, Bradsfield and Gorey, SSR, Bell and Associates Construction, Hoare Construction, IC Thomas and Associates, and C Connect. And I would also like to extend a very special thanks to our board, who continues to work to provide value to all of our members. And with that, I'm going to go ahead and turn it over to our president, Anna DeLong, who is going to serve as our moderator today. Anna.
Thank you, Justin. Hello, everybody. Before we started, a couple of quick ground rules, just so that you know why you can't talk right now. We're going to have about 100 participants on today's call. So everybody has been muted with the exception of our speakers and myself. We've got a webmaster of sorts. Catherine Hill is behind the scenes right now. She is going to be collecting questions throughout the presentation. So if you have a question to any of the questions as a follow-up that you want one of our panelists to address, just submit it by looking at the bottom of your screen. You should see a Q&A portal icon at the bottom of your screen. So if you have questions, Catherine's monitoring that, and we will try to get to those about at a halfway point today. The comment bar is not disabled. That said, I'm not monitoring that, and I don't think Catherine or any of our panelists are going to be monitoring that either. So feel free to comment amongst yourselves, but we're not looking at that to take in questions. That'll have to be done through the Q&A portal. So just a few housekeeping rules. I'm not going to spend a whole lot of time introducing our panelists. While they are impressive and amazing, we want to get right to the bulk of the content. We've got a lot of questions to cover today. So just quickly, I will introduce our speakers. We've got Bernadette Mitchell, the Healthcare Market Strategy Manager for J.E. Dunn. We've got Clay Seckman, Healthcare Market Sector Leader at SSR. Jim Langlois, Executive Vice President of Healthcare at Gresham Smith, and Randy Keiser, Vice President and National Healthcare Leader at Turner Construction Company. Without further ado, we'll jump right in. And Randy, this one's for you. In the news, we're hearing a lot of stories about makeshift hospitals. Everything from the U.S. Army Corps of Engineers and the projects that they're working on right now to what we're seeing locally at St. Thomas with the transformation of their COVID triage location. Tell us what you're seeing around the country at Turner, and what do you think it means to healthcare in the future?
Sure. I think in general, about half of our COVID work that we're doing now is for the Corps of Engineers, and the other half is for private hospitals. They range from a number of different things. I think the thing that the Corps is doing the most is convention centers. They seem to be turning a convention center into a COVID hospital pretty quickly because the infrastructure's there. There's power there, and it can. I think their logic is that it also allows them to have a staff-patient ratio that's pretty high. One of the first ideas that came out when the Corps started talking about this process, and it seemed like a year ago, but it was only 4 weeks ago, is taking hotels, they're vacant anyway, turning them into a hospital, by doing some negative air, and it wasn't very much. It was trying to run some emergency power, having some negative air, basically by just turning an exhaust fan on in the bathroom. However, it didn't seem to take off very well. Part of it is because of that staff ratio that I talked. Part of it is it's not an easy thing to take over a hotel and get a contract with a hotel, whereas convention centers and public places, the fairgrounds that we did out in California, was government owned, and they could immediately cut a deal in one day to take it over. So the process is that the state is declared a disaster area. The FEMA came in with their resources. FEMA then hired the Corps of Engineers, and then the Corps went about creating these different pop-up hospitals. The other thought was using dormitories. That didn't seem to pan out. The other thought is to take old hospitals that were closed and reopen them, or doing one in Chicago now, Sherman Hospital. That too has its challenges, because with mold or an old building, as you can envision, it's been closed for 10 years. It's a challenge to turn it around quickly. The Corps has been doing these things very fast. The contractors have responded unbelievable. We have one job that is a pop-up hospital up in New York. It's 1,039 bed hospital out in a field. That's 5 tents. 2 of the 5 tents are as big as a football field. It's $170 million worth of work in 21 days. So I think the industry responded tremendously to this challenge. All the ones that I've seen have been design build. So they're going to contractors or big firms and having them do design build. Although obviously when you build a hospital in that middle, I got feedback here. It is not necessarily. But so then the other half of our work are in hospitals throughout the United States with doing things such as adding surge capacity in parking garages, in the conference room, making private rooms semi-private, building out shell space, doing a lot of overtime work to finish up jobs that are ongoing, to be able to get those open, renovation of rooms to be able to turn it to negative air rooms. But in general, what we see the hospitals doing is working inside their property, inside their confines, whereas the Corps of Engineers is doing it out in, like I say, convention centers. Some of our jobs, unfortunately, include temporary morgues up for BI in Boston. It's kind of interesting how they're reusing N95 masks. So we have one job in New York where we took a trailer and transformed the trailer into a giant laundromat, I guess you would say, for N95 mask, and they use a hydrogen peroxide to fog the mask and sterilize them to get them back on the caregivers. The testing facilities and facilities with tents, triage areas. One job we're doing for the Cleveland Clinic is taking a huge, it has to be 300,000-400,000 square foot health education center and turning it into 1,000-bed hospital. We have, like many of the other contractors, are working 24/7. That the Stony Brook, we have over 1,000 people working 24 hours a day, 7 days a week to create surge capacity in response to COVID. And I think that going forward then is going to be a difference. And when we build hospitals, and it'll be interesting to see how it pans out. But it's certainly, I have a CEO friend of mine, he said in his 30 years of being COO and CEO, they never did a disaster drill for this type of COVID. And that will change when they start thinking about how they can do surge capacity. So, I envision going forward a lot of different things, such as being able to take a private room into a semi-private room, and being able to have changed their parking garages into an overflow, and how do you get more oxygen into the building? Those types of things that will change not only codes, how the built environment looks for surge issues that we potentially would have in the future. I don't know if that answers your question.
No, that's a great answer. It is interesting what you say. I'm interested to hear more about, what your CEO friends are saying. But the fact that, they've never done a disaster drill for something like this is just, and what that means in terms of the future, that's actually a great segue into my next question. So does any of our other speakers want to say anything to what Randy was just saying about what they're seeing out there?
I had one quick thing. We were watching the FEMA money be divided up, and the states had first right of refusal, right, Randy? And a lot of times the states would act and do their own work rather than have the Corps of Engineers jump in. So that became a bit of a dynamic that we didn't expect. So the states, if they could do it, they did. And if they got overwhelmed and desperate, they turned to the Corps. So that was a bit of a wrinkle. We chased some of that work as well, Randy, and I think that we were expecting it to come out through the federal government only. And in the meantime, the state thought it was something that they could take.
If you go, that's a good comment. If you go, when they first started, California said we got the ball, so California did theirs, and then it dropped back for probably a 2 or 3 week period where almost every one of these project FEMA money was going to the Corps. Now, within the last, if you go to the Corps' website, they haven't issued a contract since April the 6th for this, so it's kind of dropping back to local. Either that or they think maybe we peaked and maybe they don't need to continue to build these. Yeah, good point.
So that's a great, like I'm saying, that's a great segue. I want to ask Bernadette's opinion on this, but the healthcare industry, to your point about the CEOs not having a disaster drill for something like this, to a certain degree, the healthcare industry has gotten a black eye for being underprepared for COVID-19, but how does a healthcare organization prepare for an epidemic of this proportion when the associated costs are not reimbursable or revenue producing?
Sure. So I think for starters, the way COVID has unfolded is certainly unprecedented. Haven't seen anything like it for a century. So that's not to suggest that facilities haven't been doing and communities haven't been doing drills and preparing for things like pandemics and mass casualties and things. This has just, and the projections for it have been kind of off the charts, as we all know. Also, I think that preparedness looks different for different segments of the healthcare industry. So we talk about, the healthcare industry is this one thing, but there's so much diversity within it. So you have nursing homes, you have your local, state, and federal public health entities, you have the research facilities and teaching and academic medical centers, you have rural hospitals, you have telemedicine providers, you have your labs, you have level 1 trauma centers, and preparedness looks so different for each of those entities. And I think that part of what we've seen is that with all that diversity across the industry, we've seen a diverse level of preparedness and ability to respond. I think in some places, some facilities have been able to, kind of go into their surge capacity mode and been able to respond to what they have been met with, certainly with social distancing in place. All of that said, I do think that COVID-19 is going to certainly elevate prioritization of this type of disaster preparedness beyond kind of natural disasters and things of that nature. In part simply because it is just at the forefront of everyone's mind. I mean, you can't ignore it right now. So I think there will naturally be more interest, and I think even more regulatory requirements perhaps will unfold to proactively invest in this type of preparedness. And frankly, some of this is already happening just by the demand that's at hand right now. And some of this is happening in preparation for potential resurgence in the fall and winter months. So I do think our industry can help lead these conversations and help provide some thoughtful and creative solutions for how the built environment can cost effectively allow hospitals to increase their surge capacity. We've seen this with our clients in different pockets, but I think we'll start to see this more across the board. And Jim, I know you probably have some great comments about this as well.
Yeah, I think everything you're saying is what we're seeing as well.
Anna, just one comment that I would add to that, and that is when we think about preparedness, it's not just about facilities and equipment and supplies, it's also about staff training. Absolutely. And with the healthcare industry being as lean as it is right now, we've seen respiratory therapists being retrained to be an ICU nurse on a temporary basis. We've seen ER docs doing, things that are outside their lane, so to speak. So I think being prepared, we had a long talk with one CFO that said they spent way more time retraining their staff to handle the surge flow than anything else. So it's not just the tangible things, it's also staff training and getting them prepared as well.
Absolutely.
So Bernadette, follow-up question. What, in terms of the Coronavirus Aid, Relief, and Economic Security Act, what does that mean for the healthcare industry?
So just for starters, hospitals in particular, for those who may not be aware, have taken a very hard hit on their revenue side because they've had to cancel all of their their revenue generating elective surgeries and procedures. And then at the same time, your costs and expenses are rising due to all of the preparations and treatment for COVID. So $100 billion has been designed to ease, from the CARES Act that you mentioned, are designed to ease some of these financial burdens. And initially, it wasn't really clear how that would be allocated throughout the industry. This week, the first $30 billion has been direct deposited to providers across the country. And so there's a few things to note based on what we've seen so far. The first one is that the funds really only help to mitigate and to shore up some of the gaps in the short-term kind of immediate financial pressures that our clients are feeling. The second point is that the industry has been pretty vocal about how some issues with the way some of those funds have been allocated. So for example, hotspots receive basically the same percentage allocation as places with fewer cases. And it's also been distributed largely on a hospital's share of their Medicare revenue. And there are a lot of hospitals that have been very hard hit by this. Safety net hospitals would be a great example, who don't necessarily have a lot of Medicare revenue coming through. So with all the vocalizations, HHS has indicated that the remaining $70 billion will account for those concerns, although it's not really clear exactly what that will look like. So it only addresses things in the short term, but we need our hospitals and our healthcare institutions now more than ever, certainly, and that's not going to change anytime soon as this pandemic wears on. And so I think there will be more relief on the horizon. Several major hospital associations have come out this week calling for an additional $100 billion in relief. So this will be something that we'll all want to watch closely in the weeks ahead.
And Bernadette, too, the act itself sounds like it's all about healthcare, and really it's only 5% of the $2 trillion is going to the hospitals. Yes. So when you say CARES, it tends to lean toward healthcare, but it's really about strengthening businesses and keeping people solvent during this pandemic. Absolutely. So $100 billion sounds like a lot, and I guess it is, but it's only 5% of the whole pot of money.
Absolutely. I mean, you have hospitals who are receiving, maybe $5, $7, $10 million or something like that, when some of them are really hurting pretty significantly. So I wholeheartedly agree.
So what does that mean? I mean, all of this, mean for the hospital design and how that's going to be impacted post-COVID-19 in terms of, specifically what it means for surge capacity planning in the future?
Well, and is that directed at me, Anna?
Yes, sorry, Jim.
Okay,
that's directed at you.
That's okay, I thought it was. I think also the whole planning and technical aspect of what's going to happen next is really interesting. And I think there's answers to that. But I think also on the marketing side of how we market our services, I think that's where the real changes are going to happen. And I think what we're looking at is we have clients that are really business people. And for hospitals and health systems, they have a very strange dynamic. They're responsible for their business first, and then the public trust and public realm second. And a lot of times you'll look at a health system and say, well, they're there for the public, but they're also responsible back to their stakeholders, their boards, their investors. And so I think for us, when we're marketing our design services, we're going to find that there's a new requirement to help our clients sort through this. And so if you have, say, an ideal solution of how to overcome the next pandemic and prepare, it may be something that they can't afford or that it really rocks their business model. And so for us, I think a big part of what we're looking at coming forward the months to come is how do we help our clients sort through that? How do we come up with ideas of how to be prepared, but don't disrupt too much their business models? And I think that's going to become really a new thing for us to deal with. I think the response itself to pandemics is we've talked a lot about capacity surge and the need to or surge capacity and the need to increase either the acute care aspects of a hospital or the supplies. We've also watched over the last decade the leaning of hospitals, where we really tried to pull back on the amount of storage, the efficiency of staffing. Every square foot costs money. And so we've got into the point really where our hospitals and health systems run very efficiently when they run the way that they're supposed to. And when something like this comes at us, it really rocks it because the margins are so tight. So I think probably for all of us who are on the call today, we've heard a lot about the leaning of healthcare and how to make it more efficient. And I think that's probably something that we're going to see that really gets looked at in a very different way. I had an example of how clients look at pandemic design and planning. We were in Israel last year. This is the Nashville Healthcare Council. We had a delegation that went to Israel, and we went there to learn more about their health system and how their health system works and how it could work for us, and we shared the same back to them. So we toured around to a lot of their different medical centers, spoke with a lot of their government people, and we went to one medical center. This was in the northern part of Israel, and it was a former military medical center. And what they did is they, the dynamics in Israel are a whole lot different than us. We're surrounded by friendly countries, and they're not. And so they're always under the threat of war. So what they did is they built 2,000, or surge capacity of 2,000 beds underground in a parking deck. And the idea was you could move 1,700 cars out and you could move 2,000 people in. And so all the provisions for that were made. And the cost for doing that, for being prepared, was extraordinary. And when they toured us through it, it was pretty impressive. They have all the med gases and all the storage of all the different supplies and whatnot available. And to get cars out of there and people in, they could do that very quickly. But it was government owned. And so that investment that was made there for the day that hopefully never comes was something that the government took on. And what we're looking at with most of our clients when we're marketing them is how can we help them sort through their challenges? And this is going to be one that comes at us. How do we help them prepare, but don't do it in a way like Israel did because the government was paying for it? So I think for us, we're seeing really a pretty big shift in the way that we're going to be helping our clients. And sorting through these choices is really the next planning exercise. I think when it comes down to it, we're going to find that the adaptability of spaces is going to be important. If you can transfer or transform med-surg into an ICU, that kind of thing. And I think the extreme of having a parking deck converted into an acute care facility is probably something that we're not going to see much of. But you could also see where parking decks are big structures. They're usually very convenient to the hospital, immediately adjacent. And they're big spaces, right? So that you can use them for a lot of things. And storing tents and other provisions so you can convert a garage into a a care facility, even if it's triage for the ED, it's that type of stuff that we're going to see the most of, because that gets a lot of bang for the buck and a lot of big capacity. And it certainly isn't ideal. I don't think that I would like to be cared for in a parking deck in a tent. But in a storm, you take what you can get, and that's going to be what happens. That type of thing we're going to see a lot more often. And I don't know, Clay, if you had something more on the technical side you wanted to offer there.
I do, and you ask an engineer to start talking, you may take a while to shut him up. But one of the things that we've seen, historically, when we think about facilities being prepared for the future and being flexible, the traditional response is just beef everything up. If 2 oxygen outlets is great, well, let's add 4. That sort of thing. I think what we've seen during this pandemic is that the planning, what we put in the facilities needs to be a direct result of the planning for how are we going to operate in that scenario, and let that planning drive what we need and not the other way around. And sometimes, most of the time, it's difficult to get healthcare owners to do that long range scenario planning because they've got multiple bogeys they're dealing with on a day-to-day basis. So to get them to sit down and plan a day-long, Jim, that's a day-long, 2-day-long workshop to say, what if this happens, then how will we react from an operational standpoint, document that, and then let that drive what we actually put in the facility. And what we see now is that a lot of the, providing flexibility for the future, and a lot of the features that we would put in a facility simply weren't used or weren't needed. The other thought is it really depends, and we've had this discussion a lot with these surge facilities, it totally depends on acuity of the patient. Who you're going to put in a parking garage versus how many more ICU beds you need really depends on what's going on from a medical or clinical standpoint with that particular patient. Again, the ability to predict that on the owner's side or on the CDC or anybody else's side is like, pin the tail on the donkey, but that's what drives the need and the need for the quantity as well as the quality of what we would put in place.
Anna and Clay, another major shift that we're expecting is that the medical centers now are places that you don't look to go to be treated. Unless you're really in trouble, are you heading to the hospital? And they've always been a place of confusion. You pack a lot of aspects of care and administration into one little facility. And so we're expecting that the trend of having specialty care being pulled out of the hospital is going to be accelerated because of this. You're going to find that a lot of the care that you want to have, that you want to access, is going to be something that you feel good about going to a place that you can drive up to and get easy access instead of finding your way through a complex medical center. So that could be another result of the pandemic, is that hospitals start to decompress and unbundle themselves.
Yeah, I think to piggyback on Clay's comment about some of the difficulty with planning and getting our clients to plan is depending on the facility and what their role is for a particular city's disaster response plans. They don't just work in a vacuum. So these hospitals, they have kind of agreements with each other about who will take certain types of patients and how many they will take during all different types of scenarios. And then they kind of have to go back and live up to that agreement basically and assure their counterparts across the community that they'll have those. So it's difficult too, because we're not just working in isolation. It's really this more collaborative environment, and of course the more cooks in the kitchen, the more difficult it is to come out with a recipe. So
might add a little bit to what Clay just said is obviously Jim and Clay both are on the mark saying I think you're going to look at how can you be more flexible in the future for surge and the space available in the parking garage or converting a conference room. One thing I think is going to come out of that too is more robust ability to distribute oxygen throughout the hospital. I got a call from our guys up in New York, NYU Langone, last Sunday morning. Their oxygen capacity or demand far outweighed the capacity to push oxygen throughout the hospital. So they ended up being able to get a hold of an emergency oxygen tank on the back of a tanker truck, on the back of a semi-truck trailer, and then hook it up to their emergency portal and start feeding oxygen from both sides of the hospital just to get their oxygen level up to where it would be suffice. They were using virtually every single oxygen outlet in throughout the entire hospital, which far exceeds your normal design.
That's interesting. I mean, I feel like this entire kind of the answer to this question in terms of how design and planning is going to be impacted. And Jim, what you were saying about, the fact that medical centers are no longer really places that you go to get treated on the daily. It seems it seems kind of like the next best question to ask Bernadette and maybe Randy, your thoughts about patients discovering new ways to receive care throughout the pandemic. I know, I've got family members that have been on their phones and their iPads with their doctors since this started in terms of, telehealth services and prescription, deliveries at home. What does this mean for the future of healthcare delivery overall?
I think as some of the other folks have mentioned, that COVID-19 can certainly help to accelerate some of the changes that have been bubbling along here and things that we've all been talking about for a while but haven't seen just kind of change en masse. One of those would be, as you mentioned, increased telehealth. And I think not just for the outpatient care, but one of the big metrics for hospitals now is keeping their readmissions down. And so I think now this is going to propel virtual health checkpoints after hospitalizations as a tool for hospitals to use to do these virtual checkpoints with people after they've had a major health event in a hospital, so that they don't have to come back. As Jim, I think, mentioned, people don't want to go and have to navigate this huge labyrinth just to get a follow-up appointment. And now, frankly, people, I think, are going to be nervous for a little while to enter a hospital with fear that they may catch something. So I think virtual health, telehealth will become more of a tool that our hospitals are using, as well as the outpatient practitioners. I think we mentioned just being able to treat higher acuity, basically sicker patients, as that other stuff moves out. I think this certainly has elevated that. I mean, anybody who's watched the news or read anything has seen the need for more ICUs. And so, as it was mentioned, I think more adaptability. So I think we've covered a few of those already, but I'd be curious to hear what others are thinking that we haven't talked about already.
One of our guys is on the board out here at Williamson County Medical, and reported that one day, I think it was a week before last, one of their orthopedic surgeons saw 60 patients in a day, follow-up visits in a day via telehealth. And you think about the efficiency and the effectiveness of that. It's telehealth has been around. It's kind of been on the periphery. Some organizations adapting to it quicker than others. I think this is going to be a rocket launch for it. Just you see the efficiency and the effectiveness. And once the industry figures out how to reimburse providers for providing that service, I think you're right, Bernadette. I think it'll take off.
Yeah, some of the things that we've been seeing for design and planning challenges is first the intimidation of a big medical center, but also just the ease of access and being able to get in and out quickly, but also making sure you're getting top care. And the medical centers have always been the place where it's all gathered together, and you can have, in one-stop shopping, you can get the best of everything. But now you can access a lot of that online. So the telehealth movement is going to accelerate. We're seeing it already. We saw it before this, but like Clay said, I think this will really propel it forward.
I do have a question from one of our audience members. I'm skipping around a little bit because I'm trying to make sure that we're addressing questions that kind of aligned with what we're talking about. So before the webinar started, we sent out just a survey to see, what do people want to hear about? And this dovetails nicely into this conversation. So we've got a comment from Sarah Ganella, who says, several years ago, I attended an SMPS Atlanta healthcare program where the panelists spoke about smartphones being, quote, the new way to meet your doctor, and that smart devices would be used for diagnostics and to scan patients. Smart technology has been in place for years, but has been underutilized in healthcare. How does COVID-19 change this, and what does this mean for the physical building of things?
I'll take the first whack at that. I think she may not be accurate by saying healthcare is behind this. I think they're actually ahead of it in many ways. They have many systems that are happening within a hospital and within a system that are basically on the low voltage side of things. That security communications, the equipment, system controls for the buildings themselves, the RFID tracking of equipment itself. I think now the telehealth is going to be another whole aspect of it, but we see a lot of this within healthcare, and I think that the Wi-Fi systems within a hospital just themselves are inundated with people who come in with their own devices, and they clog basically the communication lines. So there's going to be a stratification of Wi-Fi, and it's going to become much more sophisticated so you can accommodate the many different levels of need. But right now, if you were to look at what goes behind the scenes in a hospital, it's pretty robust as far as the smartphones and the smart devices and the low voltage systems. I know Clay has a whole group that does this, but it once was that the low voltage systems in a hospital were the telephones and the nurse call systems, and they were almost an incidental aspect of the design. And now it can be up to 15% of the construction value can be just in those systems. So they really are taking hold, and they're much more important than ever. And Clay, maybe you can add to that.
Yeah, well, yeah, one impact I think that we're going to see it, and as with any engineering answer, it begins with the words "it depends." You think about which facilities will be impacted the most by telemedicine. I had a long talk with an owner last week who said it will have an impact, but it depends on which facilities you're talking about. Urgent care, where somebody's got a hangnail or a splint, whatever, a mild case or something, the urgent care setting seems to be easily replaced by telehealth. The MOB or POB setting, where somebody needs to go in for a retest or have some labs done or something, it may be a little more difficult to replace that with telehealth. So it really depends on the setting. It depends on the demographics. Is it a society or a community that's tech savvy or not? But I think, to Jim's point, I think it is well underway, and in places where you might not expect it. But again, I think this episode in our lives will accelerate it for sure.
Well, I've got a question for you, Clay, since I like the way you talk with your launching of telehealth and hangnails and the such. So facilities management and operations have always been viewed as a quote unquote cost center rather than a revenue producer, and therefore have occupied a seat at the bottom of the food chain in terms of funding. To what degree, if any, might this crisis elevate the built environment to a higher level of pecking order in the healthcare politics?
Great question. The reality is that plant operations or facility operations and maintenance, it has been a cost center, and the reality is it is a cost center. It does not produce revenue, and therefore any provisions for unseen needs was always a real tough argument. Hey, we need to have this equipment replaced. We need to replace a chiller. It's going to go down. It was always kind of poo-pooed because it didn't generate revenue, and the healthcare organizations strapped for capital as they are. There was always a competition, and facilities didn't always win out. But I believe this pandemic has revealed the importance of it. If you think about what you've heard in the news or through conversations with your clients about the impact of all this, if you're playing spin the bottle, look where the bottle has stopped. It has not stopped on who's got the latest, coolest MR or who just bought the doctor's practice. It has stopped on facilities. And the preparation, the provisions, the ability to handle beds, to Randy's point about oxygen supply, have we planned on our systems running 100% flat? No, we haven't, because we haven't been willing to spend that money. But it's now all about facilities and places with, air filtration and negative pressure and being able to do all those things that only facilities can do. That's what's been capturing all the news. So yeah, I believe it will raise facilities to a level to where they will get the attention. Of course, and this is just not because I'm an engineer, and I think they are the most important thing, but they may actually be. But the willingness or ability to invest in those when they're not reimbursed, when they don't increase revenue, will still be a tough discussion going forward. But I also think that we will begin to balance, because of what we've seen in the last few weeks, we'll begin to balance the discussion with, okay, what are the risks of not doing it? And we've seen, some of the risks of not doing it and having to build these surge facilities. Another thought I've had about this, Anna, is the reality of the consolidation in the healthcare industry. We are creating fewer but larger healthcare organizations, and this was kind of already started over the last year or two. But the whole departmental category of facility planning, design, construction, facility management, operations, regulatory compliance, all of that bucket seems to be elevated to more of a C-suite level. And it needs to be, because if you've got a system that's 2 or 3 hospitals or even a single facility provider, that's one thing. You've got a system like a Atrium Health over in Charlotte, or a Covenant Health in Knoxville, a Baptist in Memphis, or others. All of a sudden, those questions and answers and the planning and all that needs to go into that is much more an executive role than it was a plan operations role. I think the natural evolution of where the industry was going to begin with headed that direction. And I think the focus now on facilities in the response to this pandemic, again, just sort of accelerated it. But I think the bottom line is, I think facilities will see better funding. I think they will have a bigger clout, bigger argument when it comes to, hey, these are things that we need to do in order to provide for ... whatever that may be. And certainly this ... that we're in right now, nobody had that in a blank space, 4 months ago. And so, yeah, I think it'll have a big impact.
I mean, perfect segue. I mean, a natural evolution to where we're heading. I mean, I know there are a lot of unknowns. Basically, everything is unknown. But, and this may be a question for yourself, it may be a question for Bernadette. But how do we think that the pandemic is going to affect just the volume of work around the country, around the industry? Do you think we're going to see an avalanche, or are we going to see healthcare organizations being just so financially damaged that we'll see a freeze?
Well, as long as I've got the con, I'll take that on first, Bernadette. This is one of those questions that I firmly believe if you ask 10 people, you'll get 15 different answers. But here's what we're seeing, and we've been asking a lot of clients this question over the last few weeks, as I'm sure everybody listening in here, we're looking at workload and what's going to happen, what's going to stop. But what we've said, it's like that guy walking across that frozen pond. We're tapping that ice every step of the way. But what we're seeing, for the most part, is that and this is a little different than the 08, 09 meltdown, is that the big drivers behind a lot of these capital programs, whether that's a drive for, responding to demographics, or just a general response to healthcare reform, or we've got to replace aging facilities, keep up with the competition, whatever those drivers are, they don't seem to be being affected by this. What is being affected is the timing. And certainly the cash flow, because of the suspended surgeries and empty beds and what all they're delaying, and just the distraction from dealing with the COVID thing. They're delaying a lot of projects, but projects aren't being scrapped, and which is different than 08. 08, we saw a lot of capital programs where they said, where we thought we were going, that's not where we're going, and so they stopped a lot of things in a lot more vivid fashion. And everybody on the call has probably seen that too. So the real question is, how fast do they come back? And that answer begins with the words, it depends. I think to a large degree, do they come back in an avalanche, or do they come back as a glacier? I think it depends on the state of each healthcare organization, their demographics, their payer mix, how healthy they were going into this thing to begin with, in terms of debt ratings and bond ratings and days cash on hand and all those statistics that you read about. How strong were they going into this thing, and then how fast do they come out of it? And to some degree, it might be a little bit of a chicken and egg that we don't have. We can go borrow money right now because it's pretty cheap. The bond market's pretty advantageous right now. But do we need to get these projects started back quickly in order to return our cash flow? Do we? we could sit still, but it's, you know, what was it? Will Rogers that said, even if you're on the right track, if you just sit there, you're going to get run over. So do they try to move ahead, but do they have to have the capital project that were underway, which may speak to being accelerated? It may say that's an avalanche. On the other hand, you know, the severe cash crunch, Orlando Health, the client of ours, losing $3 million a day. And that's not sustainable. So what is their, you know, it sort of depends on how long all this lasts. Everybody knows that. But I think you have to look at, to answer that question, it's almost like you try to take a collage or a mosaic of the healthcare industry and say, how does each organization look coming out of it? And again, 10 organizations might have 15 different scenarios coming out of this.
And the worry too is that the strong get stronger and the weak get weaker. So if you do have cash on hand and you are able to buy up who is weak, it starts to pull the equality apart, and that's where the danger comes. That's where what's happened with consolidation in healthcare is, like Clay was saying, with the major systems are getting bigger, that may increase. I expect it to, actually. So having cash on hand right now is a really big advantage of someone. I think the bond market too, being low interest rates is good, but if you don't have the wherewithal to pay it back, you can't do it. But I think the big you mentioned Atrium a few minutes ago. I know that they're a very robust organization. They're probably looking at this as a great opportunity to do some of the things they've always wanted to do.
Yeah, I think I would just piggyback on that with a few just kind of macro levels. So certainly the state that the individual systems and facilities are in financially going into this is going to be a big determinant. But I think there's just some macro level things to keep in mind. So how does this whole kind of reopening of the country go? And what is that? How does it work? Does it not? Do we find ourselves with some other resurgence? You know, I think the second one is there a larger wave in the fall or the winter? And what does that look like in terms of the demand that it puts on, you know, staffing and PPE and all those types of things? How long is it until everyone is successfully vaccinated? I mean, there's a lot of differing opinions about what that looks like. And again, it's not having a vaccine, it's having everyone successfully vaccinated. Those are two different things with two different timelines. I think some of the additional federal relief that may happen for providers will play into this. And then the other piece of that, when you look just outside of the healthcare organizations themselves, is the burden of unemployment and what that places on our hospitals. So as unemployment goes up, naturally, bad debt and higher levels of uncompensated care for the uninsured and charity care go up. You know, all those surgeries, those elective surgeries that generate revenue that had been scheduled for March and April and May, will those be rescheduled? Or if someone's lost a job, are they going to forego that, you know, indefinitely? So I think a lot of those bigger trends are going to be key to watch as well.
Well, to bring it to your, go ahead.
One other thought to add to that, regardless of how fast or how slow it picks up, I don't think it'll be a matter of just picking up where we left off. Anytime there's a pause like that, it seems like healthcare owners will use it to rethink things wisely. So I believe. So whether it means a longer pause while they think about things or a shorter pause while they think about it for a nanosecond and say, now we got to go. Because we got to pick up where we left off, or we got to get speed to mark, whatever it's going to be. It'll be one or the other. But again, I think it'll depend on the specific organization situation, and to a large degree, it'll be anybody's guess.
Do you have a question from somebody who's listening about what happens when the quarantine is lifted and there's a surge for OR space, surgery centers, et cetera? Is there a way to accelerate? And I think go ahead, Jim.
It may be an operational choice there. You extend hours and you get everyone on board and cancel vacations and do that kind of move first. From a facility standpoint, those type of projects take so long that they couldn't be on board fast enough to fill the gap. I think what Randy was saying too is that there were some projects that were already begun, and there may be a heightened pressure to get those finished quicker. So if we have an emergency department up in Michigan, I think it's in New York, that was not even ready. And within 2 weeks, they pushed to get it open without having the state reviews. So that was the kind of thing that, wow, usually it takes 3 months to get to the finish line, and they did it in 2 weeks. So there's things like that that will happen. But I think for surgery, to pick up that gap, I think it's probably going to be relying on the either project's nearly finished or the operational side.
And I think we ought to be careful about, we've all, to your point, Jim, we've seen a lot of authorities having jurisdiction, be a little more lenient in times of pandemic, in times of crisis. I don't know that we should expect them to be that lenient if we're talking about facilities that are going to be serving elective or, procedures by choice. I think it'll be back to sort of status quo in terms of, no, you'll toe the line with these facilities, whereas you didn't have to with a surge facility.
Mm-hmm.
I want to circle back to something that I asked a little while ago, because I've got a comment from Sarah Ganella saying she wants to clarify just a little bit. The question that she asked about smart devices being used for diagnostics, I believe the intent of the question was more specific to users and not necessarily to healthcare providers. Do you think that there's maybe a learning curve for users, especially with telehealth becoming, to your point, Clay, what did you say, rocket launching? I want to circle back to that and just what are your thoughts on that from a user standpoint?
Well, I would have to use the words "it depends" again, because certainly our society is much more tech savvy than it was 5-10 years ago. And for us old guys like me and Randy, we've seen a surgence of that. But there's no doubt that the bring your own device to the facility has put a huge load on the infrastructure. But I think for the most part, we will see the healthcare consumer, the patient, and more importantly, the family, be more and more dependent on their own devices, riding, as Jim said, riding on the hospital's wireless to do research, to have questions answered, to, do whatever they, find that information that they know is out there, and to be able to sift through it to see, what's the best course for their family member. So I think whatever we do going forward, we're going to have to accommodate that, and our technology folks will tell you we're having to do that in a very big way. I think that will only continue.
Also, there was another aspect, Clay, I think you told me a story when you visited me last, that nurses, when the nurse call switch is flipped and a patient's asking for help, the nurse calls devices will actually track their response time, and then it will be analyzed back to the number of days that the person's in the hospital, and there could be a correlation between how responsive nurses are to how many days before you're released. And they may find that the use of smart devices may end up helping with analytics and trying to to increase the effectiveness of nursing or other care types.
Yeah.
We got another question in, bouncing around just a little bit, but I want to ask this. We've got freestanding emergency departments are not permitted in Pennsylvania today. Do you see project types that are not currently permitted becoming permitted as a result of this outbreak, especially for ambulatory buildings that are beyond a hospital campus?
I'm on the FGI guidelines, and I think those types of changes take some time. I mean, we're pretty much towards the end of finishing up the new guidelines for 2022, so. I would think the answer would be yes, maybe. It's not going to be very quick, though. I would think it would take years, and I guess if this just goes away pretty quickly, then maybe it'll be forgotten, and maybe that wouldn't. But on the other hand, if this comes back this fall and it's on the minds of a lot of legislators or the FGI guidelines or whomever. Then you could probably see some changes.
I think also a major change that could happen is on the CON side, states that have CON restrictions, and even like in North Carolina, the lack of shelf space being allowed, that type of thing that would be nice to have right now. But it's done in a way to sort of slow the growth and even the playing field. You might look at that differently now. So I think CON laws are something too that need to be considered.
I would agree totally. I've heard several owners say if we didn't have CON laws, we would have had more capacity in place than we had when this thing started. Yeah, I totally agree.
One more question from some of the listeners. What are the panel's thoughts on the previous trends of outpatient facilities being the main focus of healthcare systems going forward? Or healthcare system growth going forward, excuse me.
Well, I think that the purpose for outpatient is being able to get many of the procedures that were done in a very expensive environment in the hospital out into the community. And one is convenience, but probably more important is the cost, as everybody's looking at being able to drive cost. So I don't see that as being a major change, because I think the overriding thing is that going forward, that we're going to have to continue to be able to drive cost in the entire healthcare arena. It'll be interesting to see if how the leaders in the government agencies respond to this, because pandemics happen about once every 100 years. So will we be changing how we do business because of one event that happens every 100 years? Or does the scientists think this is going to become more common, and we need to be able to change significantly how we deliver healthcare because of this?
I'll add to that. I think that the trend towards outpatient will continue just because of the effectiveness, the efficiency. That said, though, you go back 5, 10, 15 years ago, and what we were being told is we don't need any more beds, we don't need any more ORs, we don't need any more EDs. Well, over the last 10 or 15 years, we sure have been designing and building a lot of ORs, a lot of EDs, and a lot of beds. And so you look at the current state of the healthcare built environment, average age of plant, ability to operate efficiently in a building, in a complex that was built, X number of years ago. There's still a huge investment to be made in modernizing, in replacing and upgrading our inpatient facilities just to get them up to speed. And certainly what we're building now is so different than what we were doing in the 40 years I've been doing. I can guarantee you there's a lot changed. But I think that will continue. So it'll be a balanced approach. I think you've got to respond to both. The next question is, how do we respond to what happens when we transition from fee for service to a value-based or a capitated kind of model? You want to see telehealth take off, that's when it's going to take off. But what does that mean for what we build? Certainly be a big push for outpatient, taking services to the community and that sort of thing. But that'll be maybe the next curveball that the industry has to deal with.
Well, that's a great point. I mean, to that point, we got another question. Speaking of community, will community hospitals return as a result of poor quality healthcare to rural residents?
That's a tough question. I mean, to Jim's point, I think depending on how much the financial, apple cart is tipped over in all of this, I think that can go one of several different ways. And I think we haven't quite seen yet how COVID-19 is playing out in some of there's been a lot of attention on what's happening in the metropolitan areas, and we still have yet to see how that's all going to unfold in areas beyond kind of the major urban centers. So, Jim, I'm curious to hear your thoughts.
Well, I think the whole premise behind critical access hospitals is going to play out in the more rural areas where the government has to step in, and they have to help these hospitals do business because they can't afford to care for the thin populations they have in those areas. So something's got to give. I think what Clay had said about value-based healthcare versus fee-for-service is really a major driver. I think what we're going to see here is that wellness becomes a bigger part, and even the insurance companies start having a bigger play on how healthcare is delivered. And I think the ambulatory question that was earlier, It really, it goes back to the business of doing healthcare. I mean, I think that this is really an interesting conversation, because when it comes down to it, healthcare is private business. Whether it's for-profit or not-for-profit, it's still private business. And how do they run a business? And you have to either look at it from a moral standpoint, what is the right thing to do, or from a more of a practical standpoint, business standpoint. And when those things collide, you have to make decisions, and that's where the complexity comes. I think all of us who are here on the panel, our biggest part in this whole calamity that's happening is helping our clients sort through the choices, because there's not rules that are in place today that they're going to fall back on and make good decisions. They're going to have to reassess things in a very fresh way. And I think the whole idea of a business being run and doing what's right for the community is really a hard question to answer.
Yeah. And I would add to that, I think the community hospital, the degree to which they'll be able to survive, I think may depend on how well connected, to what degree they're part of a network or an organization or a system that can share economies of scale and that sort of thing. Can they survive on their own? Yes, no, maybe so. It's difficult. We're seeing fewer and fewer being able to do that. But there is the need. Jim mentions critical access hospitals. We're seeing the need for community hospitals that are really a triage and an overnight stay with a whole bunch of telemedicine rooms that are connected to a mothership, in the next biggest city, which is where all the specialists are. So it'll be different solutions for different parts of the country, but I think that care has to be provided to these rural communities, and I think the industry will figure out a way to do that.
In terms of providing clients with solutions, what you were saying, the business of doing healthcare, Jim, I feel like healthcare owners were already overloaded before the crisis started. As business developers, how do we stay close to owners when they're already so drastically unavailable?
Well, I think when this first started in March, we as a company sent out a lot of offerings to our clients to say, hey, we're here for you. We can offer you some things that may be useful. And we wanted to make sure that they knew that we were a resource. So we did that without really knowing what the reaction would be. We didn't want to appear as ambulance chasers, and we didn't want to look like we were pestering them, but it was a way of connecting with them. And what we found was a lot of people came back, a lot of our clients came back and said, we appreciate that. We will rely on you when we need you. And since then, it's been a very strange dynamic. We've had a lot of projects at the user meetings that we normally have a lot of. I think healthcare, more than most client types, building types, we have a lot of meetings. And the user meetings have all been stopped. For the most part, obviously they're all busy. So that aspect of what we do has really been halted in a big way. The project management level and dealing with the active projects has actually increased. I think we get much more attention. We have the response back from our clients is quicker. I think even the conversations are a little bit more personal. You can chat a bit about where you are, what you're doing, and you get to know your client even better than before, I think. I think even the connection of seeing someone's house and seeing them in their, their casual wear it's made a little bit more of a connection between our clients and ourselves. But that's at the project level. And I think the C-suite, and I think Clay said this, is a lot of our work is going towards centralized planning and C-suite thinking. That's where the biggest gap we find has happened, is we can't connect with them as easily because they're busy and they're thinking about different things. What we have to do is be valuable enough to them that they want to call us and take our calls. But I think going forward, when this all settles down a bit, it probably will be a new day and it won't be the same as ever before. I think we will get back to it, but I think the trick is going to be for us to stay with the connections that we have with our PMs running projects and find a way that we're valuable to the C-suite. And then the input that happens on the user level, hopefully that comes back, because what they generate, what they provide for influence over design is really important. But it won't be the same. I think it will, even some of our meetings that we've had over and over with showing up on a Tuesday morning at 10 o'clock and having a series of user meetings, we're talking now about doing a lot of that by way of video conference. And it may be our skills are going to be much different in the end. We're going to be much more, Zoom, WebEx, Skype, Teams. I mean, we're going to master these softwares. Never mind being great healthcare planners and designers and contractors. We're going to be the master of how to communicate using all these different softwares.
If it
It's a
doesn't
game
kill us
changer.
first.
Or if it doesn't kill us.
And it might.
So that's a really good point. I mean, I feel like going from the conversation of, the C-suite and having that gap to just the job site and people boots on the ground. I'm interested to hear, Randy, building and design services are considered essential. So has COVID-19 changed the way the job sites are functioning? And what do you think the implications are going to be going forward just in the future period?
Yeah, the short answer is yes, drastically changed. And I think a lot of these changes may well stick for quite a long time. I think our two focuses is obviously making the job site safe and making sure that the people that come onto the site feel like they're safe. Those are two different things. They don't feel like they're safe on the site, they're not going to come to work. We've had in northern parts of the United States and some union areas, if they don't feel safe, they can go home and they can collect unemployment. And there's a gap on some unions. I know the electricians that will pay them full time for being at home. So they could get set at home, get paid full time. If they don't feel safe on the site, that's an easy option for them to do. So to be able to get the jobs done and to be able to make sure that people are safe, there's a lot of different things, and I can just kind of rattle them off to belabor the point. But it's making sure when they first start with setting coming on site that they have the proper gloves and a mask. And we were trying to get a mask on everybody on site. Then as they come onto the site, doing a health screening and take the temperature of every one of the people. It was a funny side note to that is that we ordered 3,700 thermometers from China. They got held up and forever in customs because they were thinking that we're going to resell them. And they were actually for our use on every one of our jobs throughout the United States. So taking the temperature and health screenings utmost important, all that before they even set foot on the site. And then as they go through the gates, the very first thing we do is pre-task planning, and the pre-task planning goes through, are we social distancing? And if we're not, what are the extra precautions? Construction's not easy to do if you're 6 feet apart away from everybody else. So we have, when you put the plan together, extra PPE, extra face masks, we then have many of our jobs have staggering start times so that not everybody comes into the job site at once. You can start and have your staggering start times, of course, obviously end times, and staggering lunch times and break times. So you have very few people in a break room at one time, and you can get you can get 6 feet apart from the other other folks. And that's a challenge when you're working, basically there's many of our jobs that are working close to 24 hours when you start staggering them out and then working a night shift. So for the construction managers, that's a different approach of how you staff a job. And it's all the way down to the little things of, it's tough to get the workers up and down the job site elevator, the buck hoist, without being within 6 feet of one another. So I saw a picture from one of our jobs where you had the squares on an elevator, and basically you only can take 4 people up at once, and minus the elevator operator, you're down to 3 people carrying them up at once and still getting them 6 feet apart. Extra cleaning, extra hand washing stations, and it's a challenge because typically you wouldn't have hot water on a construction site, at least not early on the construction site. And we try to follow the CDC guidelines, or we do follow the CDC guidelines, and they suggest hot water for washing. So it's different general requirements on your project, be able to get hot water, hand sanitizers, onto the job. So there is some kind of interesting byproducts of this. I think we are becoming a little bit more efficient in the fact that we're not on top of one another. We're spreading out the work and make a conscious effort to spread out the work. I know for a fact that our safety record has been better in the last month, and I wonder if that's because of the detail we go on into of how we're working our jobs. Would be interesting to see what that result was for. And then there's some new tools they're coming out that's kind of interesting. Actually, I got one yesterday where you can track every worker on your site, and you can have a history of were they ever closer than 6 feet to another person, and then you can track if somebody tested positive, then you know who the other people are that need to be tested in the future because they were within 6 feet. So a lot of different things that came out of this, and I think many of those things will be still used going forward.
I wonder what everybody, and just to let everybody know and let the people who are phoning in know, we're getting towards the end of my questions and towards the end of a lot of our audience questions as well. But I wonder from the participants' perspective, from your perspective, what the silver lining is for us in all of this COVID-19.
Anna, I think we could have an entire session on how does this change how we work going forward. And I know every firm out there is probably having the same discussions that SSR is, but if we started over here 4 months ago, 3 months ago with this is how we're doing work, we're traveling or we're working in the office, whatever that status quo was, we're now all the way over here with the working from home and learning how to do it. Do we ever go all the way back over here? And I think absolutely not. I think to Randy's point, this has driven I think we're going to look back and go, why did we ever do it that way to begin with? Why would we not let, designers and technicians and people that are generally in the office, let them work from home a day or two a week? Think about the positive impact on quality of life, getting a few cars off the road at rush hour, all that sort of stuff. I think this will profoundly impact how we do work. We've learned that, and guys my generation, whatever, we've always had this certain, I guess, reservations about working from home because we assumed everybody would be goofing off. Well, we've been doing it for a month now, coming on 2, and productivity is great. We're getting jobs out the door, so why not stick to it? The work we're doing in Florida, Jim, I know you all are seeing the same thing. We used to have to travel to Tallahassee for every ACA stand up every time. It was just beat a pat Tallahassee. They're doing everything, including final site inspections virtually now. Well, for a stand-up review or an 80%, why would we ever go back to doing it the way we used to do it? So I think we're going to see all kinds of small and big things that will improve our efficiency. I think, obviously, some of what we do actually sort of bottles things up. Having a panel discussion like this instead of a room full of people where you can read body language, is it as effective? I don't know. It certainly can be done, but I think when we look back, we'll all have a long list of things that will change and change permanently just because we were forced to.
It was interesting, Clay, that last week I did a presentation for a $1 billion job at CHOP, and we did it all remotely on Teams. Mm-hmm. And it was great because you can have some notes in front of you. There's some things that you can wear shorts as long as you tie on. but the challenge was reading people's expressions. I have no idea if they fell asleep when I were talking or they were very interested because you couldn't see them. But
you can't read the language. Yeah. I do have a concern though, if we try to have technical meetings, and we've all seen this, our clients really don't understand what we do a lot of times. If we're trying to explain something to them that's highly technical, if I'm sitting across the desk or table from them, I can read their language. They're not getting it. And so I can adjust, I can slow down. But if I can't read that, if it's voice or even on a video, and we just sort of like ships pass in the night, I think the guy's understood what I've said. He doesn't have a clue, and then 6 months later, you've got a big issue because there was a miscommunication.
I think also for everyone that's on this call, we're all interested in marketing our services for healthcare, and healthcare is in the center of this storm, and it's the time to rethink how we market, what's effective, try different things. So the exciting times are yet to come, right? The mundane and
Yeah.
what we've been doing over and over is gone. We're going to end up doing something very different for the next, well, whatever, for foreseeable future.
Yep. Crazy times, but amazing outcomes. Well, that's it. I don't have any more questions. And man, this has been an insightful conversation. I just want to reiterate that how much we thank you guys for coming on and participating in this. And then also
Thanks for having us.
Yeah, absolutely. Let all of our callers know we have recorded this and we'll send it out, a link to it out after we hang up here. And to remind everybody that we've got a couple of things coming up. Be on the lookout for exactly what we're talking about now, a virtual communication series. Learn how to use some technology and present with the same type of vigor that you would do in person, but virtually on the computer. So that information will be coming out soon. And I thank everybody for calling in. It's been a great conversation, and we will send you the link to the recording. Thank you guys so much.
Thank you.
Thank you.
Great one.
Good job, President Dunn.